Namaskar dosto, welcome to channel Toxicology and Board. Today in this video we'll be discussing about the DABT topic NOAEL as well as BMD. BMD is nothing but benchmark dose. Okay, let's directly dive into the question. So the question is in evaluating the dose response relationships, the benchmark dose approach offers what advantage over the NOAEL approach? If you look at typical toxicology study, you will be getting two types of endpoints. Basically, uh, one is that you are deriving, particularly I'm talking about repeat dose toxicology. I'm not talking about acute toxicology studies. So you will be getting NOAEL, okay, or LOAEL, and there is another toxicology descriptor that is little bit new when compared to NOAEL approach. That is something called benchmark dose (BMD). Okay, that BMD you are getting it from a study based only, but the results generated from the study, the group of studies which will be kept, which will be uploaded in a software. That software will give you BMD benchmark dose. It will give you that benchmark dose also at 0 for BMD 05 you will be getting, BMD 10 you will be getting, BMDL you will be getting, the lowest confidence interval at which benchmark dose is observed, that you will be getting. So for some of you people, it might appear that these terms might appear a little bit of new, but we will be learning about this in detail in the in further discussion. Okay, so we will be seeing. Let's see what are the options. Let's again understand the question. The question is in evaluating dose response relationships. There are two are there. Benchmark dose approach, how it is advantageous over NOAEL approach. The traditional method is NOAEL approach. Comparatively new method is BMD approach. How BMD approach is more useful when compared to NOAEL approach. That thing we are going to, that is a question, that thing we are going to learn in this particular uh, question. So we have options. Establishes a mode of action for threshold effects. Okay, what is mode, what is mechanism of action, that you will not come to know from the from this approach. Mechanisms always you will be learning. There are different types of toxicology studies are there, that you will be understanding from mechanistic toxicology. Okay, if it is a pharmaceutical, how the drug is acting, that you will be learning in efficacy, that mechanism of action is different. Okay, coming to how the drug is toxicology or causing adverse effects, that you will be learning in mechanistic toxicology. Okay, so mode of action for thresholds, no, that I don't think that is the right answer. Let's see. Then next we have option number 2, provides greater certainty with fewer animals. Always remember, whenever the sample size is decreased, then it becomes very difficult for us to statistically justify. Okay, for in order to establish statistical significance, n level should be more than 3. Okay, for OECD, if you see 408 repeat dose toxicology studies, ICH of OECD guidelines, it suggests that at least 5 per sex per dose should be there. Okay, if you go to cancer studies, more number of animals will be there. If you go to reproductive studies, fertility or FED or EFD studies, more number will be 10 per sex per dose or 20 per sex per dose will be there. Earlier for cancer studies, 2-year bioassay, there used to be 50 per sex per dose. But I'm talking about repeat dose toxicology studies where it says that too. I'm talking about the short duration, only 28 day. There it is 5 per sex per dose. Okay, but coming to, if you see Indian guidelines, NDCT 2019, it says 6 to 10 animals per sex per dose. That is the given. Okay, so the option B, what it is saying, trying to say is that by using fewer animals, you can explain, provide greater certainty. No, with fewer animals, no. I don't think that it will be lead to actually uncertainty. You cannot statistically justify your results if you have fewer animals. See, animals should be less. We have to follow 3R principle, no doubt. We have to respect the things which are suggested by either CCSE or ICAC, ISEUC. What are the animal ethics committees are there? No? We have to respect there, and we have to follow, implement the 3R principle. No doubt. But the number of animals which are already suggested by the regulatory body, you're taking less than that animals. No, that kind of data will not be useful for your regulatory submission, or you cannot even justify your results with such fewer animals, right? The next we have option number 3, establishes a mode of action for non-threshold effects. So this is similar to like that of the option A. Okay, it is mode of action for threshold effect. Threshold effects means the dose, there is a certain dose at which there is an effect. So dose is related to effect. There is a threshold will be there like 5-fold, 10-fold, 50-fold, 100-fold. Coming to non-threshold means, for example, genotoxic, whether you will be having a result either positive or negative. For example, skin sensitization, you will be having either the chemical is positive for sensitization or negative for sensitization. You cannot establish concentration or dose. But again, as I said from the previous video, there are exceptions. Today, we are able to establish even concentration dose also related with respect to sensitization. So many articles are there, even in the case of cosmetics or RIFM or SCCS guidelines, there are suggesting that we are able to establish a concentration gradient response sensitization is also there, where we are deriving sensitization के लिए also we are deriving some endpoints are there. So let's not go there. So option C. Then let's see what is option D. Option D is includes a measure of variability in the data set. Okay. So coming to BMD, as I said, no, you take 10, 15, 20 studies, you will be taking, put it in the software, then you will be getting BMD. Unlike NOAEL, NOAEL is for one study, you will have for one effect, you will be having one NOAEL. Okay. Within the study, for adverse effects on the kidney, one NOAEL might be there. Adverse effects on the systemic toxicity, one NOAEL will be there. Adverse effects on the local toxicity, one NOAEL will be there. So different NOAELs within the study will be there. But again, that based on target organ specific. If you want to understand in a very simple terms, means there will be a lot of example dose response curve examples are available. Take the effect of alcohol on the on an individual. You plot a dose response curve. What you'll be getting, for example, here we'll see. For example, a person is consuming alcohol. What is it? For example, 50 ml is taking. He will be having sedation or lethargic. At 100 ml, maybe he will be having dizziness. At 200 ml, he will be slowly not able to remember, or speech will be, or he will be having incoordination in movement. And again, more for 400 or 500, he will become unconscious, and more than that he will get death. Okay, the same chemical at various concentration or various doses, it is showing adverse effects. Okay, so what I am trying to say is, first it is affecting your CNS, then it is affecting your what is it, your liver, then it is causing death mortality. So like that only includes a measure of variability in the data set. Okay. So what is the right answer is option D. Option D, as I said, no, it is includes a measure of variability in the data set. Coming to benchmark dose includes a measure of variability where the NOAEL does not, where the NOAEL does not. Okay. See, NOAEL approach will not consider measure of variability, whereas BMD approach will consider measure of variability. That is the key point that you have to remember. Okay, take home message. It also allows consideration of the shape of the entire dose response curve. For example, if you see a traditional NOAEL method study is there. For example, you have control to 0, and you have low dose, mid dose, high dose. For example, it is 50, 100, and 500 like this. You are able to study the effects only at these three points, 50, 100, as well as some 500, some dose. But coming to BMD approach, at every data point on the dose response curve, you will be able to study. That is the advantage of BMD over NOAEL. It allows consideration of the shape of the entire dose response curve. Getting my point? And permits a specific benchmark response level for RfD calculation. What is this RfD means? You have, in the case of US NOAEL, EPA, you will be having two endpoints are there. For oral route, it is called oral reference dose. For inhalation, it is called inhalation reference concentration. Okay. To calculate that RfD, it is similarly like HPEL, health-based exposure limits are there. It's a bigger umbrella. Under that, you will be having PD, you will be having AD, you will be having OEL, you will be having. For medical devices, TI will be the tolerable exposure or tolerable intake. For ISH M7, you will be having acceptable intake. Like that, HBL is a bigger umbrella in which you have different different toxicological HBELs will be there. In that RFD is there. RFD is something which is used by US EPA. Okay, so the basic formula will be RFD is equal to NOAEL by uncertainty factor UF1 into UF2 or 10 into 10 factor. Intraspecies into interspecies factor will be there. So let's see in second slide what we have. So, uh, so what you have to learn from this, the concept that we have to learn from this question is which is the better POD. POD is here, it is nothing but point of departure, the starting dose which you will be using to calculate either HBL or HED, like that. Okay, so we have two types of point of departures are there. One is NOAEL, another is BMD, benchmark dose. So what is which is better? Whether we have to go for traditional NOAEL method or whether we have to go for the more advanced method, that is BMD approach, which is better, that we are going to see. So let's understand. So both NOAEL and benchmark dose can be used as point of departure. Correct POD. Okay, to derive RfD. RfD, I don't know, it is reference dose, oral reference dose, or inhalation reference concentration. In the US, and DNEL, derived no effect level, which is used in European Union. For example, in the case of ECHA-rich doses, those toxicologists who are working, those scientists who are working in ECHA, they will come to know about this term DNEL, derived no effect level, which is given by European Union. Again, this is also a type of HBL only, comes under that only, health-based exposure limit. Another, in that it comes under DNEL. Okay, so the BMD approach is now EPA's preferred approach. Yes, nowadays US EPA is saying instead of going for NOAEL approach, please use BMD approach, and is fast becoming the world standard for dose response analysis. Definitely. And what you have to learn, okay, I'll tell you later. The BMD approach has distinct advantages over the NOAEL approach. What are those advantages? In that modeled benchmark dose, as I said, no, BMD 05 as well as BMD 10 reflects the shape of the dose response curve and is less affected by the choice of the experimental concentrations. However, the BMD approach requires a robust data set. As I said, no, you need 10, 20, 30 studies you need. Then only you can put it in the software. Then it will generate you a single dose response curve where each and every data point on the dose response can be used. Okay, additional knowledge and statistical modeling. This, I don't think this is are freely available, this software. So in the past 10 years, what I am observing in the toxicology when I do the literature search, there are very few published literature available for the chemicals for which direct BMD or BMDL10 is available. Okay, if you are working in a certain organization, you have that software, you people can yourself generate a BMD. As such, BMD availability, those values, descriptors in the public literature, I have not come across as many as I come across NOAEL. Okay, nowadays, today also, if you look at FDA study, the FDA pharmacology review, I'm talking about pharmaceuticals. The toxicology studies, the endpoint, what they're expecting is NOAEL, not BMD. BMD might be useful for risk assessment, but the primary objective of conducting any toxicology study is first to identify the NOAEL, and that NOAEL is only applicable for the FDA also. So that is probably one of the reasons. Once the regulatory mandates that for a certain chemical you need to have a BMD, then I am sure that you will be getting more BMDs directly available in the literature. Okay, so let's see a small comparative table between NOAEL and BFD. One is data and design requirements. NOAEL must be one of the doses used in the studies. As I said, no, low control, low dose, mid dose, high dose. Out of this low dose, mid dose, high dose, one will be your NOAEL. Okay, sample size reduces statistical power. As I said, no, at least n should be there. Sample size के बारे में I already told. As per ICH or OECD, it is 5 per 6 per dose per repeat dose, 28-day repeat dose tox studies. But coming to NDCT to the 19 Indian guidelines, it is 6 to 10, it is 6. So N is important. N is number of sample size or observation is less than 3, means that cannot be used for your statistical application. Then precision, coming to BMD, precision on dose should be good. If not, it should be no and accounted for. This is very important. Precision of that particular doses is very, very important in the case of BMD analysis. Coming to effect of sample size per dose, smaller sample size leads to larger noise. So if you, as you know, how the everything is connected. See, if the sample size is more, you'll be getting larger noise. For example, another the division between the doses is also very important. For example, you have within a study, 28-day study, repeat dose study, you have a control 0, low, and you have low dose 10, mid dose is 50. This is again 1000 something like that. There is a huge gap between mid dose and high dose. Okay, you're getting my point. That should also not be happen. So what is happening between 50 and 1000, to understand that thing is it. So when you're designing the study, how many fold of doses you are considering while designing the study, that is also very important. Smaller sample size leads to smaller BMD in the case of BMD. Okay, so there is a completely opposite. Smaller sample size, larger NOAEL. Smaller sample size, smaller BMD. Okay, it is directly proportional to the sample size. BMD is directly proportional to sample size. The last important point, effect of number of dose groups or number of publications. Fewer doses leads to larger NOAEL. Fewer doses leads to smaller BMD. Okay, in the case of NOAEL, you have fewer doses which are leading to larger. As I said, no, but there are certain exceptional studies are there in which see, the typical study design is you have to have control, you have to have low dose, you have to have mid dose and high dose. But there are few studies where mid dose again is divided into low mid dose and high mid dose. Okay, and there are also SAD/MAD studies are also there. Sometimes, sometimes ascending toxicology, ascending dose toxicology studies are there, where more than 5 doses, 6 doses, 7 doses within that study design will be there. Particularly preliminary studies will be there, no dose range finding studies. There you are using huge number of doses you are using with small sample size. Then based on the results from this dose ranging finding studies, you will decide the doses for the actual main study. Okay, so fewer doses leads to larger NOAEL. Coming to here in BMD, fewer doses leads to smaller NOAEL. Again, fewer doses are directly proportional to this BMD. Okay, so the important thing that we have learned from this question is that about the NOAEL, the comparison between the NOAEL approach, the traditional method, and the BMD benchmark dose. How BMD is superior, having more advantages towards NOAEL approach. One thing you need to understand, whenever we are bringing any new concept to the scientific community, or it will not be accepted immediately. It will take some time. BMD can also, it will take some time to generate data. As I said, no easily availability of BMD values in the public literature, in the articles I have not come across. Okay, those who are having access to the software, they themselves can generate the BMD. But eventually I'm sure, back 10 years it was very less, but today at least few of the publications, they do have BMD for chemicals. So eventually it will take some time for the data to develop, where each and every chemical will have one BMD will be there. Okay, okay, fine. So thank you so much. Be curious. For any questions, please write a mail to arya.priyanka18@gmail.com. Like, subscribe, and follow my YouTube channel Toxicology on Board. All the best for your exam. Thank you.